comfortable, if she's up on an examining table, is she on her left side, all of those things to make sure that it's not really just an isolated elevation of blood pressure. I mean, we could wait an hour and recheck it, but really the right thing to do is to um, give her 4 hours, at least minimum, and recheck her. Sometimes in practice, what we'll do is, check the blood pressure as she arrives. If it's elevated, maybe before she leaves. If it comes back down before she leaves, was she nervous? Was she anxious? Is this more of a sympathetic response to, my baby's coming, I'm getting closer to dates? But if it's still suspicious, and obviously if any other symptoms like a headache or spotty visual changes accompany that, well, then that's certainly, and the weight changes, that's certainly something that we have to pay close attention to. But we want at least 4 hours apart. We wanted to see that blood pressure over 140/90, and she's got to be in her 20th week or beyond if we're going to really tag her with a gestational hypertension diagnosis. If she's showing with hypertension early on in the pregnancy, the really the consideration has to be, did she always have hypertension? And that, pregnancy certainly doesn't make that better. And you remember, we're talking about young, healthy women who may or may not have had consistent health care up until their pregnancy. So, if they haven't seen a doctor in 2 years, who's to say if their blood pressure was elevated or not? So 20th week and beyond, and this develops, is pretty much classic gestational hypertension. Now, if she's just hypertensive and she hasn't progressed to any further in the disorder, that means we're not going to see any protein in her urine. And likely, if that's all she has, we're just going to monitor her. And in rare cases, if the blood pressure continues to climb without any other symptoms, no neuro symptoms, no liver symptoms, no renal symptoms, well, then it's likely she could have some low-dose cardiac meds or antihypertensives. Should resolve itself within 6 weeks after the delivery. However, if mom has this hypertension that develops and then begins to spill protein in her urine, protein that's measured between 1 and 2 plus on a dipstick. We just do a quick random dipstick of the random catch. If there's 1 to 2 of proteins in the urine, then we'll call her mild preeclamptic, because it's not just her hypertension. She's having some renal changes as well, and we know there should be no protein in the urine. The body needs protein. The kidneys are good at holding on to that. And then finally, to move on to severe preeclampsia, this is a woman who's experiencing not only the hypertension, and her hypertension could actually be borderline, but it's all the other stuff that tells us, whoa, there's lots of stuff going on here. So she definitely is spilling protein, usually greater than 3. She starts to notice, or we notice, that she's not putting out as much urine, and her creatinine can start to go higher than the 1.2. She starts to have these visual changes. She starts to have those headaches. She starts to develop hyperreflexia, which again is another assessment and indicator of the systems that are impacted by this disorder. So if she's starting to have neurological changes, it's a reasonable expectation that she could develop and show us that she's hyperreflexive. So we do check the reflexes on our moms who have gestational hypertension. Most often the patellar reflex is what we're looking for, and they would be brisk, right? +3, +4 would be an indicator that she's having those changes. We can also assess for clonus. Clonus is when we hyperdorsiflex the foot, and we bear back on the ball of the foot. And as the foot relaxes, it actually bounds. It's almost like a little contraction or a mini seizure of the foot. And we measure it in beats. We call 1 beat clonus, 2 beat clonus, meaning did the foot tap my hand once? Did it tap it twice? Boom, boom. Or did the foot come back? So it would look like this. So if the foot's up and I just gently push on the ball of the foot, if it goes, that would be 2 beats. If it goes back once, it's indicating the hyperreflexia. And then those hepatic changes that can lead to the upper congestion, so the epigastric, the upper quadrants. And if there's liver involvement, it's likely going to show in my lab work for sure. So I'm going to probably see thrombocytopenia. So I'm going to see those platelet counts well below 150 to 400 being normal range, right? Got to know normal ranges. So these are, and their LFTs could be off as well. So those are the things that we're going to look for when we're caring for our client. I'm going to pause this video, and then we're going to pick up with what HELP syndrome is, eclampsia and HELP syndrome, because that's really, when we're unmanaged, where we're heading. Be right back.